Okay, so today we're going to talk about a couple different types of hemorrhagic stroke. The first one we're going to talk about is the subarachnoid hemorrhage, which is going to occur in the subarachnoid space. So as we know, we have the three layers of meninge. We have the outer layer, which is our dura. We have the middle layer, which has kind of spider-like protrusions, which is our arachnoid. And then we have the inner layer that acts kind of like a cellophane that covers the brain, and that's our pia. So by just the name itself, we can kind of assume that a subarachnoid hemorrhage is a type of hemorrhage that's going to occur below the arachnoid, or basically it occurs below the outer layer of that arachnoid meninge. So what's going to happen is there's vessels that come through here. One of those vessels is going to rupture. Generally, it is an artery, and it's going to cause excessive amounts of blood to build up in that arachnoid space. So we know that we're looking at rupture of a vessel or vasculature below the arachnoid space, or the arachnoid outer membrane. And like we mentioned, what's going to happen is we're going to have an accumulation of blood, or a buildup of blood within this arachnoid space or below that arachnoid membrane, and that's going to allow increased pressure in onto the brain, and that's going to cause a lot of stroke-like symptoms. So if we're looking at subarachnoid hemorrhage and what causes a subarachnoid hemorrhage, the most common cause of subarachnoid hemorrhage is an aneurysm within the circle of Willis. So again, if we take a look at our brain and we take a look at the circle of Willis, generally it's going to be on the posterior portion of the brain. So picture us looking up at kind of our brain from below, and the circle of Willis is going to sit underneath the brain. It's going to allow for collateral circulation, so that we don't have issues if we have a blockage in one of these areas. The problem with the circle of Willis that it is prone to aneurysm, and an aneurysm in the circle of Willis is what's going to cause us to have this subarachnoid hemorrhage. So if we take a look at what happens, one of two types of aneurysms are going to form. So we're going to get what's called a Berry aneurysm or a saccular aneurysm. If we take a look, what's going to happen is if we have a piece of this circle of Willis that gets an aneurysm that kind of looks like this, it's what we call a Berry aneurysm or a saccular aneurysm. It's called Berry or saccular because it's a little sac that comes off of the artery, and it kind of looks like a berry if you've seen it. If we take a look, here we can actually see these are those little sacs or little berry-like protrusions that are coming off of the arteries within our circle of Willis. And what happens is, as this Berry aneurysm or this saccular aneurysm gets larger, so that was a Berry aneurysm, like the other types of aneurysm we talked about, or like our aneurysms that we talked about in the aorta, we get a weakening of the vessel wall, or we have basically a stretching until our vessel becomes very weak. And what that's going to make it prone to is a rupture and having blood exit. We can also have another type of aneurysm called a fusiform aneurysm, and this looks more like the aneurysms we talked about in the aorta. So we have an aneurysm that really is just stretching or dilation of that wall, and again, same things are going to happen. We're going to have increased weakness of the arterial wall. It's going to make it prone to rupture. So that's a fusiform. And if you take a look here, we can see the two different types that we're talking about. So we have our saccular aneurysm, again, that looks kind of like a berry coming off of the circle of Willis, or we have a fusiform aneurysm, which is really just weakening dilation of that wall. Either way, what's going to happen is we're going to lose the integrity of that tunica media. We're going to lose the integrity of that muscular layer of our artery, and it's going to make them prone to rupture or bursting. The problem with having one of these aneurysms rupture or burst within our circle of Willis is that it doesn't allow for our collateral circulation to make up the difference. So generally, if we have a blockage in our circle of Willis, say we have a blockage here, we have the ability to reroute blood flow to all these other areas because it's a circle. The problem with an aneurysm is as the aneurysm ruptures, so say our aneurysm is somewhere in here, and blood flow is normally flowing through the circle, as the aneurysm ruptures, blood is just going to exit the circle of Willis. So it doesn't really make a huge difference in terms of having this collateral circulation. If I have a large amount of blood exiting the circle of Willis itself. So sure, we have all these other pathways that blood can travel through, but if no blood is making its way to these pathways, then we're not going to have circulation, or we're not going to have perfusion of the areas that we need to perfuse. So that's a big issue with an aneurysm, especially one, again, that causes subarachnoid hemorrhage, which is normally found in the circle of Willis, is that it really bypasses the function of that collateral circulation. When we take blood away from the circle of Willis, well, it doesn't matter how much collateral circulation we have, we're now not supplying the amount of blood we want to supply to that area. So a few things are going to happen with this type of stroke. So obviously we're going to have extensive bleeding into this space. Remember that our arachnoid is still below our dura, so we're going to have a lot of blood building up essentially between the brain and the hard outer space of the dura. So what's going to happen is as pressure builds, it's going to put pressure on certain areas of the brain. So we start to see a number of specific signs and symptoms when we're looking at someone who develops a subarachnoid hemorrhage. So if we take a look and start breaking it down, what we're going to see, there's a number of specific things that are related to this type of hemorrhage. So let's draw our little man and start breaking down the signs and symptoms we're going to see with him, and we'll start explaining why. So we know what's happening in the brain is we have our circle of Willis, and we're having a rupture. So what's happening is something is bursting, some sort of aneurysm is bursting within the brain, and we're having blood exiting at generally a fairly high rate from the circle of Willis. So generally, what we're going to see in the initial instance of a subarachnoid hemorrhage is a patient who may have an initial loss of consciousness. So this patient will generally have an initial LOC followed by a lucid interval. So we see a decrease in LOC, and that's usually followed by a lucid interval. So we think about why that's going to happen is we have bursting or rupture of one of these aneurysms, and that's going to allow for a large amount of blood to start exiting the aneurysm. So if we kind of draw that out further, we have our circle of Willis, our internal carotids here. So say we have an aneurysm here, or we have a aneurysm that's formed and it's now bursting somewhere in our circle of Willis here. So we're going to start to have blood exiting at a fairly fast rate from this area of the circle of Willis. So blood starts exiting our circle of Willis here. If we think about what happens when this bursts, so when this aneurysm bursts, we're going to have an extensive amount of blood leaving that area at one time. So the body's not going to be able to compensate initially. So what happens is we have a drastic reduction in cerebral perfusion pressure, or the amount of blood and oxygen that we're supplying to the brain. So because of this initial burst, so aneurysm bursts, and we have a rapid drop in cerebral perfusion pressure, or CPP. Because of that drastic drop in CPP, the patient is going to go unconscious. If you think about someone who stands up too quickly or has orthostatic hypotension, what happens is the body can't compensate for that loss in blood supply to the brain, and what happens is they don't have enough oxygen supplied. The person goes unconscious, they lie flat for a little bit, and they're going to return to consciousness when blood supply is returned. So what can happen in this baryaneurysm or subarachnoid hemorrhage is we have rupture of the artery. It's going to cause drastic reduction in CPP initially, and then hopefully the body's going to be able to rebound by compensating. So if the aneurysm is not that big, or blood's not leaving as quickly as it could be, the patient can hopefully maybe coagulate a little bit in that area, reduce blood supply to that area by vasoconstriction, and reroute blood around it. In those instances, the patient should regain consciousness, and this will be our lucid interval. So basically what's going to happen is the body's going to reduce blood loss, hopefully from that aneurysm, or it's going to compensate. By using things like collateral circulation. Again, this is not going to happen in that person who has a large aneurysm burst. Very similarly to our AAA or thoracic aneurysm, this is a very large aneurysm, and we have an extensive amount of blood being lost at one time. The patient's never going to regain consciousness. And there are high incidences where people who have a subarachnoid hemorrhage die pretty much instantly as a result of the bursting of the aneurysm. So we're looking at that case where the hemorrhage is not as severe and the body is able to compensate. So in these patients, you may see an initial loss in LOC followed by a lucid interval. In terms of prodromal symptoms in these patients, we don't see the normal prodromal symptoms that we see in ischemic stroke. And if you think about what's happening in ischemic stroke, is we're literally losing blood supply to a certain area of the brain. So we're starting to see that something's blocked in the ischemic stroke. One of those areas is blocked, and prodromal symptoms are related to decreased blood supply to those certain areas. So people get vision disturbances, or they get impairment in gait, or they get clumsiness or inability to ataxia, or they have an inability to move a limb the way they want to. It doesn't usually last a long time, or it may be simply a TIA that's happening. But those prodromal symptoms are related to those direct effects on that artery. Usually, again, it's atherosclerosis and plaque buildup. In this case, our prodromal symptoms are not the same. This patient has an aneurysm in their circle of Willis. The aneurysm may be burst, or it may just be getting larger and putting pressure on surrounding areas. So if we're talking about prodromal symptoms in these patients, usually the circle of Willis does a good job at maintaining collateral circulation and getting blood flow to certain other areas if we have an aneurysm present. Even if we're leaking a little bit of blood out from a aneurysm that is small and ruptured, or maybe isn't completely ruptured yet, we can still supply blood to those other areas. So you shouldn't see, or you're not often going to see, a lot of symptoms like the vision disturbance and the clumsiness or impaired gait that you see in the ischemic stroke. The more likely prodromal symptoms of these patients is headache. So if you think about what's happening, if I have damage to an artery, I have aneurysm that's getting larger and putting pressure on the brain, that's going to result in pain or headache because I've got pressure on certain areas of the brain that's going to stimulate some of those nerve fibers. So prodromal symptoms in these patients occur in terms of headache. So we get a prodromal headache usually. So prodromal symptoms usually occur in the form of headache. So we can see an LOC followed by a lucid interval. We can see prodromal symptoms in terms of headache. And then if we're looking at what's going to happen in terms of other stroke-like symptoms, we can really see pretty much all of the other symptoms that we expect in that patient who's having a stroke. So we can get things like facial drooping. We can get our hemiparesis or hemiplegia. We can have our impaired gait. We can have our dysarthria. And it's important to remember the mechanism that's causing these. So different than our ischemic stroke, where we have a blockage of the artery that supplies those areas of the brain that are responsible for these functions, in this patient, it's going to be a result of decreased blood flow and increasing pressure. So as blood continues to leak into this subarachnoid space, what's going to happen is that's going to put pressure on the brain, and it's going to start to compress those areas of the brain that are responsible for these kind of symptoms. So if we look at the ischemic stroke versus the hemorrhagic stroke, your patient with a hemorrhagic stroke is more likely to see or more likely to show progression of these symptoms. So they have the prodromal headache. They may have the LOC followed by a lucid interval. And they may have development of these symptoms, but you would expect this patient to continually get worse if the hemorrhage hasn't stopped. So as the hemorrhage continues and continues on, these patients generally progressively get worse. And in terms of our ischemic stroke, we don't usually see that progression or those symptoms getting worse. We have a blockage in a certain area of the brain that's preventing blood flow to that area, but it shouldn't start affecting other areas that are not supplied by that artery. In terms of our hemorrhagic stroke, as this basically area of hemorrhage or area of pressure continues to widen, we're going to see more signs and symptoms added on until the patient eventually is going to go completely unconscious. And if it isn't corrected, they're going to die. So just to kind of recap, what we're seeing in a subarachnoid hemorrhage is we have bursting of an aneurysm, generally present in our circle of Willis. So we get either this saccular aneurysm or this fusiform aneurysm, which again, if we're looking at aneurysms, it's just a weakening of that arterial wall, destruction of that tunica media, and eventually as blood flow increases to the area and puts pressure on the area, it destroys that tunica externa, and we have rupture of this aneurysm. Because of that rupture, we start to have blood exiting the circle of Willis, and we have blood accumulating in that subarachnoid space. So some of the signs and symptoms we can see are prodromal in nature. So as the aneurysm is getting bigger or is in the initial stages of rupture, the patient may have a prodromal headache. We may see a decrease in LOC followed by a lucid interval. As we have that rupture, we reduce cerebral perfusion pressure, and then the body is able to compensate. We'll likely see a lot of our typical stroke-like symptoms, so things like facial drooping, slurred speech, hemiparesis or plegia, impaired gait, pronator drift, all the things we would normally expect. But in our hemorrhagic stroke, they're generally going to be progressive, or they're going to be getting progressively worse as we go along. And often these patients are going to complain of things like the worst headache that they've ever had in their life. So 10 out of 10 headache, usually the pain's going to radiate down their neck. And they're going to describe that as the worst headache they've ever had. So again, prodromal headache, and then we may see that continue on. So worst headache of their life. Usually radiating down the neck is what we're going to see with that as well. It's another good picture here of this berry aneurysm. So you can see how large that aneurysm is, and it's eventually ruptured. So this patient's going to likely have those prodromal headache because they have that that aneurysm that's increasing in size, putting pressure on the area, and going to cause them to have those other issues. These patients, as it gets worse, you may also see things like blown pupil, and that's going to occur when we start to have basically pressure onto the brainstem or herniation of the brainstem into the foramen magnum. And we're going to talk about that when we talk about what happens when we have an increase in cerebral perfusion pressure.